Chapter 4, Part 2. Now let's talk about what makes patient care handover effective. A handover isn't just passing along information. It's the transfer of responsibility for the patient. Once that transfer happens, the next provider is relying entirely on the information that we give them to continue care safely. During a patient handover, it's critical that the information we share is clear, concise, and relevant. This includes the patient's chief complaint, what we found during our assessment, the care we already provided, and how the patient responded to that care. It's also important to avoid unnecessary details. A good handover focuses on what matters right now. Too much information can be just as harmful as too little, especially in a busy or high-stress environment. Effective handover helps prevent errors, reduces delays in treatment, and ensures continuity of care. When communication breaks down during a handover, important details can be missed, duplicated, or misunderstood. Patient care doesn't stop when we arrive at the hospital. A strong handover is part of patient care and is just important as anything we did on scene or during transport. When you're giving handover, start by initiating eye contact with the person receiving the patient. This helps ensure that we have their attention and lets us confirm that they're ready to receive the information. A handover should never be rushed or delivered to someone who is distracted or walking away. We should manage the environment as best we can by trying to minimize noise, interruptions, and distractions whenever possible. In busy emergency departments, though, this isn't always easy. But even small steps like moving a few feet away from alarms or side conversations can make a big difference. It's important to remember that the distractions during a handover increase the risk of a missed or misunderstood information. If you're interrupted, pause and pick up where we left off rather than trying to talk over the distraction. Before completing the handover, though, we need to ensure that the ABCs are addressed. Airway, breathing, and circulation always come first. If there's any immediate life threats, these need to be communicated clearly and prioritized before moving on to less critical details. A good handover is clear, organized, and focused on patient safety. Let's talk about how to organize the information that we're giving. One of the best ways to provide a clear and effective handover is by using a structured report. Two common formats you may hear are the SBAR or SBAT. These formats keep you organized and help ensure that nothing critical is missed, especially in high-stress situations. The SBAR: situation, background, assessment, recap, or treatment. Situation is who the patient is and why they're here. Background is the relevant history and events leading up to now. Our assessment is our findings and the patient's current condition, and then recap or treatment is what we've done and what still needs to be addressed. So this is what this might sound like. This is an 85-year-old male presenting with chest pain that started about 30 minutes prior to our arrival. The patient has a history of hypertension and high cholesterol, no known drug allergies. His chest pain began while mowing the lawn and did not improve with rest. On our arrival, the patient was alert and oriented, pale and diaphoretic. Initial vitals were a BP of 158/92, pulse of 104, respirations of 22, and an SpO2 of 96 on room air. 12-lead EKG was performed and transmitted to your facility. We administered 324 milligrams of aspirin, applied oxygen 2 liters via nasal cannula, called for ALS, and ran a repeat 12-lead during our transport. Patient states his chest pains improved slightly but are still present. Using a structured format like this helps the receiving provider quickly understand the patient's priority condition, what's already been done, their current state, and what might need to be done next. In addition to our verbal report, our documentation must support the handover. Our written report should clearly reflect the patient's priority condition, any prior care provided, the patient's current status, and immediate or anticipated needs. Remember, if it didn't get documented, it didn't happen. Handover isn't just about giving a good report, it's just as important to know how to receive one. Make sure that we're maintaining eye contact, stop what you're doing if possible, and give the provider your attention. Eye contact shows respect and signals the information being shared matters. Managing the environment, just like when you give a report, the environment matters when you're receiving it. Reduce noise, limit interruptions, and avoid multitasking. Ensure understanding. If something doesn't make sense, ask for clarification. This is not a time to assume or guess. A simple question now can prevent a serious error later. You might need to ask, can you repeat that last set of vitals, or has the patient received any medications yet? Before the provider leaves, summarize what you heard. This confirms shared understanding and closes the loop. Finally, make sure that you receive any additional paperwork or documentation, such as run sheets, medication times, or belongings. These details support continuity of care and proper documentation. Receiving report is an active process. Your attention, questions, and summary help ensure the patient gets safe, seamless care. Up until this point, we've talked a lot about verbal communication. Now we're going to shift to something just as important, written communication and documentation. Our patient care report, or a PCR, this is the primary written record of everything that we do. You may also hear it referred to as a pre-hospital care report. It's the same thing. This is extremely important to understand, but your PCR is a legal document. What you write or don't write can be reviewed by hospitals, your supervisors, medical directors, lawyers, and even the court. If it isn't documented legally, it didn't happen. The PCR records all patient care from dispatch to hospital arrival. This may include the initial complaint, assessment findings, vital signs, treatments provided, the patient response, any changes in condition, and finally, the patient disposition. It's going to tell the entire story of the call. There are two types of PCRs, a written or paper or an electronic. Most systems today use electronic PCRs, but the expectations are the same: accuracy, clarity, and completeness. Your PCR is how you communicate with everyone after the call is over. Even if your verbal handoff was perfect, the PCR is what lives on. On the next slide, we're going to talk about what makes a good PCR and how to document in a way that protects the patient and you. Let's talk about the PCR and what it actually does. Your patient care report isn't just one thing. It serves 6 critical functions. Continuity of care. The PCR allows the next provider, whether that's the ER nurse, the physician, or another EMS crew, to understand what the patient complained of, what you found when you got there, and what you did, and how the patient responded. If your documentation is poor, the patient's care can suffer after you leave. Second is compliance and legal documentation. This is where we circle back to something I said earlier. The PCR is a legal document. It proves that you followed protocols, that you performed appropriate assessments, and that your care met the standard. If your actions aren't documented, you can't prove that they actually happened. Third is administrative information. This includes times, unit numbers, crew members, locations, and dispositions. This information is used by supervisors, QA officers, and the service itself, not just the medical staff. Fourth is reimbursement, and this one surprises a lot of people, but EMS agencies do not get paid if your documentation is incomplete or incorrect. No documentation equals no reimbursement. So yes, documentation literally keeps the doors open to your agencies. Oops. Fifth is education. PCRs are used for training new providers, case reviews, QA and improvement discussions, and learning from both good calls and bad calls. Your PCR may be used as a teaching tool long after the call is over. And finally, data collection. PCR data is used for quality improvement, system changes, research, state and national EMS statistics. Your PCR tells the story of the call when you're no longer there to explain it. It's going to protect the patient, the EMS system, and you. What actually goes into a PCR? This is the core information that tells the patient's story from dispatch to hospital arrival. First is the chief complaint. This is the patient's primary reason for calling 911, in their own words if possible. If the patient says, "My chest hurts," that is their chief complaint, not our diagnosis. Next is the mechanism of injury or illness. For trauma, this explained how the injury happened: a fall, an MVC, an assault, etc. For medical cause, it explains what led up to the illness. This helps receiving providers predict hidden injuries and complications. Third is the level of consciousness or mental status. This includes things like alert and oriented, confused, lethargic, or unresponsive. Mental status changes can be the first sign of a serious problem, so this must be documented clearly. Next is vital signs. You must document initial vital signs and ongoing vital signs, especially if the patient's condition changes. Trends matter just as much as the individual numbers. Then we're going to document the initial and ongoing assessment. This includes our primary assessment findings, our secondary assessment findings, and any changes that we observe during care. If something changes, it should be reflected in your PCR. Next is the patient demographics. This is going to be any identifying information: name, age, birthday, sex, address, etc. Accuracy here matters for both medical and legal reasons. And finally, transport information. This tells the rest of the story. Where was the patient transported? What was the mode of transport? What was the patient's position during transport? What were their conditions on arrival at the hospital? And who was care transferred to? The PCR should allow someone who is not on the call to understand: why was the EMS called? What did you find and what did you do? And how was the patient when we arrived at the hospital? Let's talk about the administrative information that goes on a PCR. This is the timeline of the call and is just as important as our medical documentation. These times are not just for paperwork. They're used for system performance tracking, legal documentation, quality improvement, and even reimbursement. If your times are inaccurate, it can create a serious problem for both you and your agency. Key administrative timestamps include when the incident was reported. This is when the 911 call was first received. The EMS unit was notified. This is how quickly EMS was dispatched after the call came in. The EMS unit arrived on scene. This is your response time, one of the more closely tracked EMS metrics. The EMS unit left the scene. This helps show how long patient care occurred on scene and supports decision-making for rapid versus delayed transport. The EMS unit arrived at the receiving facility. This documents transport time and can be critical in time-sensitive cases like strokes, traumas, STEMIs. Patient care was transferred. This is when the responsibility officially changes hands. Care does not end when we arrive at the hospital. It ends when we give a report and physically transfer care of the patient. The unit back in service. This shows system availability and unit readiness for the next call. Let's say a trauma patient arrives late at the hospital. If our PCR shows a delayed dispatch or a long on-scene time or even a delayed transport, these timestamps may be reviewed later. Accurate times help protect you, your partner, and your agency. Never guess on your times, and never just copy them from your memory later. Enter them as close to real time as possible and make sure that they make sense and order. We're provided these times through our CAD via ECC and can upload them into our PCR, which makes it super easy to ensure that we have accurate times. The administrative section of the PCR tells the story of how EMS moves through the call. When combined with our patient care documentation, it creates a complete and defensible record. Now that you understand what goes into a PCR, let's talk about the types of forms you may see. The traditional written PCR is historically PCRs were paper-based. Like back when I started in EMS, they were written copy PCRs. They included checkboxes for quick data entry and a narrative section where we explained the calls in our own word. Paper PCRs are still used in some systems, especially as backup documentation when electronic systems may fail. However, these paper PCRs came with some challenges. Some people's handwriting was difficult to read. Sections could easily be missed, corrections must be clearly explained and initialed, and reports could get lost or damaged. Because of these issues, many EMS systems transition to electronic documentation, or a computerized EPCR. This is what we use in our system. These systems also include drop-down menus and checkboxes and guide us through the required fields. Time-stamped events are imported automatically, and they reduce missing or incomplete data. This screenshot here shows you an example of a real PCR interface. Not the system that we use, which I'll show you guys in class, but a different system. Even though EPCRs help you, they do not replace good documentation skills. You can still choose the wrong option, copy information incorrectly, or write a weak narrative. The computer doesn't fix bad documentation. We have to do that. Regardless of whether the PCR is an electronic or paper copy, the narrative section is critical. This is where we explain why we did what we did, we show our clinical decision-making abilities, and we protect ourselves legally. In the real world, your PCR may be reviewed by your supervisors, a CQI committee, attorneys, and the hospital staff. Document every call like someone who wasn't there will read it later, because likely they will. The big takeaway here, though, is technology helps us standardize our documentation, but accurate, honest, and thorough reporting is still always our responsibility. Let's talk about some standardized narrative formats that are going to help us write clear, organized PCRs that make sense to anyone who may read it later. One very common format shown here is the chart method. We're going to talk more about the D-chart format in class, but for now, let's talk about the chart method. C is the chief complaint or chief concern. This is why EMS was called, in the patient's own words if possible. It's generally short and specific and quoted if appropriate. This may be chest pain, shortness of breath, or a fall with some hip pain. The history. This is where we tell the story. This is going to include the events leading up to the call, the onset, duration, and progression, any relevant medical history, medications or allergies as appropriate, and this section should explain how we got here. Assessment. This is what we found. our primary and secondary assessment findings, the mental status, physical exam findings, and vital signs, both initial and the changes. Here we stick to objective findings, what we saw, heard, and measured. Treatment. This is what we did. This includes our interventions performed, oxygen, positioning, splinting, medications if administered, and the patient response to the treatment. And also, if we didn't do something, we would explain why here. Transport. This is how the call ended. This is going to include the mode of transport, any positioning of the patient, changes of the patient en route, condition of the patient when we transferred care, and who we gave report to. This closes the loop. So here's a real-world narrative of what this might look like. The 62-year-old male complaining of chest pain. Patient reports sudden onset substernal chest pain approximately 30 minutes prior to EMS arrival while shoveling snow. Patient describes the pain as 7 out of 10, non-radiating, associated with shortness of breath and nausea. Patient denies trauma. Past medical history includes hypertension and hyperlipidemia. Patient reports taking lisinopril daily. No known allergies. A. Patient's alert and oriented times 4, pale and diaphoretic. Patent airway, respirations labored at 24, lung sounds clear and equal bilaterally. Radial pulses strong and regular. Initial vital signs BP 158/94, heart rate 102, respiratory rate 24, SpO2 93 on room air. Treatment. Patient placed on oxygen via nasal cannula at 4 liters with improvement of SpO2 to 98%. Patient positioned upright for comfort. Aspirin administered per protocol. 12-lead EKG performed and transmitted. Patient reports pain decreased to 5 out of 10 following treatment. Transport. Patient transported emergently to the hospital with continuous monitoring. Vital signs remain stable en route. Care transferred to the ED staff with a verbal report given to RN Smith. Patient condition stable upon transfer. Another standardized narrative format you may see, especially in a healthcare setting, is SOAP. SOAP is commonly used in hospitals and clinics, but you may still see it referenced in EMS documentation or on an exam. Subjective. This is what the patient tells you. This can include their chief complaint, symptoms, the description of their pain, and any patient statements. This information is subjective, meaning it can't be measured. For example, I feel dizzy or my ankle hurts. Objective. This is what you can see, hear, measure, and assess. This is going to include the patient's vital signs, any physical exam findings, their mental status, any observable signs such as bleeding or deformity. If we didn't observe it, it doesn't go under objective. Assessment. This is your clinical impression. This is our field impression, suspected condition or problem, and any changes or trends. This isn't our diagnosis, but just our assessment. Plan. This is what you plan to do or did. This includes treatments provided, a transport decision, and any ongoing care. Regardless of whether you use chart, D-chart, SOAP, SBAR, or another format, every narrative section should contain the same core information. This isn't optional. This is what makes our PCRs legally defensible and clinically useful. All narrative sections should include the time of event, for example, dispatch time, patient contact, treatments given, transport, and transfer of care. If it's not time-stamped or sequenced, it didn't happen. Assessment findings. This is what we found on our exam. The patient's mental status, the vital signs, the physical exam findings, etc. We don't want to just list the vital signs. We need to show what they meant. Emergency medical care provided. This is what we did for the patient. Did we put them on oxygen? Did we provide splinting or bleeding control? If we touch the patient, it belongs here. Changes in the patient after treatment. You must document the patient's response to care. For example, did their pain improve? Did their breathing get easier? Did the vital signs stabilize? Or was there no change noted at all? Observations at scene. This sets the scene for anyone reading the report later. Some examples that go here: mechanism of injury, environmental hazard, and any witness statements. This helps to justify our assessment and our treatment. The final patient disposition. What ultimately happened to the patient? Were they transported to the ED? Did they refuse care? Were they released to another provider? Or were they transferred to a helicopter crew? Refusal of care, if applicable. If the patient refuses, it must clearly be documented. We need to also include that the patient had capacity, the risks were explained, signatures were obtained, and any witnesses that were present. As we've talked about before, refusals are high liability calls. The staff person who continued care. We need to document who we handed patient care off to. for example, the name of the nurse or the physician or maybe the ALS provider in which you transferred care to. This is going to close the loop for continuity of care. Your narrative should allow someone who was not there to understand exactly what happened in order without guessing. Next, we're going to talk about health information exchanges, or HIEs, and why they matter to EMS. What is an HIE? A health information system is a system that a health information exchange is a system that allows secure sharing of patient health information between EMS, hospitals, and other healthcare providers. The goal is simple: better information, better patient care, and better continuity. HIEs improve the sharing of data between EMS and other healthcare providers. This means the information that you document in your PCR didn't disappear after you dropped the patient off. It can actually follow the patient through the healthcare system. HIEs allow providers to access relevant health data, such as medical history, medications, allergies, and prior encounters. This is especially important when a patient can't tell you their history. HIEs also reduce unnecessary duplication of data entry. If EMS already documented something accurately, the hospital may not need to re-enter this information. This is going to save time and help reduce errors. HIEs also allow EMS to access patient outcomes related to hospital care. This is how agencies can find out what the final diagnosis was, what happened after arrival, and whether the treatments were effective. This is huge for quality improvement. HIEs also allow contribution and access to health information both on a regular basis and during disasters. In mass casualty incidents or evacuations, HIEs help to track patients across facilities. But keep in mind, HIEs only work if our documentation is accurate and complete. Bad PCRs don't just affect billing, they affect the entire healthcare system. This slide explains how most HIEs actually function, HIEs function This slide explains how most health information exchanges actually function using what's called a SAFER system. If you remember nothing else about HIEs for National Registry, remember SAFR. The SAFR framework: search, alert, file, and reconcile. This describes the full cycle of the patient information moving between EMS and the hospital. Search. Search means the systems can search for existing records. This includes hospital records, prior EMS encounters, and other available health records. This is especially useful when the patients can't give you a history. Alert. This means that HIE can notify hospitals of incoming patients. This may include EMS activations, patient demographics, and basic clinical information. Think of this as an early heads up for the receiving facility. File. This means the data is incorporated directly into the patient's health record. What you document in your PCR can become part of the patient's permanent medical record. This is why accuracy, professionalism, and documentation matter. Reconcile. This means outcomes and other data are sent back to EMS agencies. This includes information used for billing, quality improvement, system performance reviews. And this is how EMS finds out what happens after the patients arrived at the hospital. This section focuses on reporting errors and what to do if a mistake is made in documentation. This is extremely important for both patient safety and for your career. Do not cover up errors. If you leave something out or record it incorrectly, do not try and cover it up. Mistakes happen, but what really matters is how we handle them. Covering up an error almost always makes the situation worse. This also brings up falsification. Falsification means intentionally changing, altering, or misrepresenting information in the patient care report. Falsification results in poor patient care, may result in suspension, and may even lead to legal action. This can include loss of certification, termination, and court involvement. If you make a mistake on a handwritten report, the correct way to fix it is shown here. You should draw a single horizontal line through the error, initial the correction, and write the correct information next to it. We don't ever want to scribble, erase, or use whiteout. EMS documentation must always be honest, accurate, and transparent. So let's talk about what to do when an error is identified, either while we're writing the report or after it's already been submitted. If you discover an error as you're writing your report, the correction process stays the same. Draw a single horizontal line through the error, initial it, and write the correct information next to it. If the error is discovered after you submit the report, you still follow the same basic principles. We don't want to delete it, overwrite it, or try and hide it. Instead, you follow your agency's correction or addendum process while clearly documenting what was corrected and why. In an electronic PCR system, though, this is going to look like creating an addendum, clearly identifying the error and correcting it with a time-stamped and traceable entry. Electronic systems are designed to track changes, and that's going to help protect us when we use them correctly. Now let's talk about documenting a refusal of care, which is one of the highest risk situations that you'll encounter in EMS. Refusals are a common source of lawsuits in EMS, and because of that, thorough documentation is absolutely critical. If it isn't documented, it didn't happen. Even if a patient refuses transport or care, we must still document any assessment findings and any emergency care that was provided prior to the refusal. A refusal does not mean no documentation. We should clearly document that the patient was alert and oriented and demonstrated decision-making capacity, and also that they understood the risk of refusing care. This is one of the most important pieces of a refusal PCR. The patient should also sign the refusal of care form. If possible, also have a family member or law enforcement or someone as a bystander sign as a witness. The witness strengthens our documentation but does not replace a good narrative. If the patient refuses to sign the form, we should also document that clearly. We need to include that the refusal was explained, the risks were discussed, and then the patient declined to sign our PCR. Even with the refusal, we must still complete the PCR in full, which is going to include assessment, findings, patient statements, any education provided, and a final disposition. Refusal calls often look simple, but usually they're the one that comes back years later. Clear, thorough documentation protects the patient, our partner, our agency, and us. When it comes to refusals, our documentation should clearly show that the patient made an informed decision, not just that they said no. Let's talk about special reporting situations. These are incidences that, depending on our local or state requirements, may require additional documentation or mandatory reporting. Not every EMS call is documented the same way. Some situations trigger legal reporting requirements, and it's critical that you know what must be reported and how to document it appropriately. Gunshot wounds are commonly mandatory reportable incidents. We should provide patient care first and notify the appropriate authority per local policy and document objectively. Stick to the facts. Avoid any speculation on how or why the injuries occurred. Dog bites also often require certain information to be reported to law enforcement or animal control. Our documentation should include location of the bite, any circumstances as reported, and any information about the animal if known. Again, document what we observe and what the patient states. Some infectious diseases must also be reported to public health authorities. This is especially important for exposure tracking, community health, and responder safety. Follow your agency's exposure and reporting policies. Suspected physical or sexual abuse is one of the most critical special reporting situations. EMS providers in Virginia are mandated reporters. We should document our findings objectively, use the patient's exact words when possible, avoid any leading questions, and follow our local reporting procedures. You're not responsible for proving abuse, only reporting the concerns. In an MCI incident, documentation may be altered due to use of triage tags, limited time, and some scene safety concerns. But even in an MCI, we need to provide care, categorize our patients, and provide transport information. On all of this must still be documented thoroughly as possible. In all specific reporting situations, we need to be factual, objective, thorough, and follow our local protocols. We should never omit required reporting because the call was uncomfortable or complicated. Special reporting situations protect not just the patient, but the community, our agency, and us as providers. Communication systems are one of the most important tools that we use in EMS. Radio and telephone communications link us and our partners with dispatch, other EMS units, and fire and law enforcement. Without reliable communication, it becomes much harder to coordinate care, request resources, and keep everyone on the same page during an incident. Effective communication helps the entire response team work together more efficiently and safely. It allows us to give patient updates, receive information, request additional help, and notify hospitals of incoming patients. Communication systems often provide a layer of critical safety. If a scene becomes unsafe, our equipment fails, the conditions change, we're able to communicate this quickly and can protect both us and our patients. Base station radios. Base station radios are radios that stay in one fixed location, such as the dispatch center, or your fire station, the hospital, or an EMS headquarters. These systems contain both a transmitter and a receiver, which allow for two-way communication between field units and a base station. Because they're stationary, base station radios usually have stronger antennas and more reliable coverage than our portable radios. A two-way radio system allows both sides to send and receive information, which is critical during responses. In some systems, this communication happens through a dedicated line, also known as a hotline, which provides direct point-to-point contact between EMS and the hospital or medical control. We have the ability to just switch to whichever med channel we would like to use to contact the hospital. These dedicated lines reduce delays and ensure clear communication, especially during high-risk or time-sensitive calls. Mobile radios are radios that are permanently installed in the emergency vehicle, such as an ambulance or fire engine. These radios are powered by the vehicle and typically have a stronger signal and better range than handheld radios. Mobile radios are most often used to communicate with dispatch and medical control while the unit is en route, on scene, or transporting a patient. Let's say we're responding to an MVC on a highway. We may be talking to dispatch on one channel and potentially interacting with incoming resources on a different channel. As we transport the patient, we may switch to a med control channel to give our report to the receiving facility, all without losing contact with the dispatch. This allows our crews to stay informed, coordinated, and safe throughout the call. Portable radios are handheld radios that we carry with us when we're away from the ambulance. These radios are essential because patient care doesn't always happen right next to the ambulance. Whether we're inside the house, down an embankment, or spread out across a large scene, our portable radios allow you to stay in constant communication. You'll hear me mention throughout class, this is also a personal pet peeve of mine. Please always make sure that you or your partner one carries a radio. This can become a resource for us, a lifeline, and a huge safety component plays into this. A repeater-based system uses a special type of base station radio called a repeater. The repeater receives a radio message on one frequency and then automatically transmits that message on a second frequency. This happens almost instantly, and most of the time we don't realize it's occurring. The real benefit of a repeater is that it allows two mobile or portable radios to communicate with each other when they normally wouldn't be able to. Because the repeater is usually located on a tower or a high elevation and uses more power and a larger antenna, it greatly extends the range of communication. This is especially important in EMS when units are spread out over large areas and operating in locations with poor radio coverage. Keep in mind, in our county, there are parts of the county that we still don't have good radio communication, and this can provide a challenge on some calls. So make sure that you're familiar with your radio capabilities in the areas that you do not have radio service. What you're seeing here is how a repeater-based system actually works in real life. When a message is sent to the control center or dispatch, it's often sent to the repeater site through a landline or network connection. From there, the repeater broadcasts the message out over the radio system so field units can hear it, even if they're far away. When we talk about digital equipment in EMS, telemetry is one of the biggest pieces that we'll use in the field. Telemetry allows electronic signals, like heart rhythms, to be converted into coded signals that can be transmitted to another location. These signals can be sent via radio, telephone, or cellular networks, and then decoded at the hospital so the providers there can see exactly what we're seeing in real time. Many EMS systems take this even further by using Bluetooth-enabled mobile devices. Data from our cardiac monitors, like the patient's EKG and vital signs, and sometimes even their capnography, can be transmitted directly from the monitor and forwarded to the receiving facility. This is going to speed up care, improve decision-making, and allow hospitals to provide even before we arrive. So what does this look like for us? Let's say we're treating a patient that's having chest pain, and our cardiac monitor is showing a STEMI. We capture a 12 lead, we're able to transmit it to the hospital directly. The ED and the cath lab can review this EKG while we're en route. They're going to have the cath lab activated and have everything ready to go when we pull into the bay. This is going to save time for our patient and really make a difference in their outcome. In EMS, one of the most common ways that we communicate with receiving facilities is by cellular phone. Cell phones essentially function like a low-powered portable radio, but allow for more direct and private communication. They're often used to give patient care reports, clarify destination decisions, and speak directly with med control without tying up radio channels. In some environments, satellite phones are used. These can be used when traditional cell phone service isn't available. These phones connect directly to satellites rather than cell towers, making them reliable during disasters, large-scale incidents, and areas with poor coverage. It's also important to remember that radio scanners can pick up radio traffic, which means your conversations can be overheard. And this is why it's important that patient-specific information is not communicated directly over the radio. So, for example, I'm transporting a patient that I'm going to stroke alert. I should call the hospital from my cell phone and give them the patient's demographics and things like that would be included in my patient care report to let them get the patient registered and activate the appropriate physicians prior to our arrival. I don't want to give this information via the radio, again, because anyone out there can pick that information up, so we should not be relaying patient demographic information over the radio. Also of note, if you're transporting your patient to Sentara RMH, they prefer to receive their radio reports via cell phone, so we'll call into the charge nurse and speak to them via cell phone, whereas if you're transporting your patient to Augusta Health, we're going to reach them on a med channel. Beyond radios and cell phones, our ambulances are equipped with several other communication tools that may help keep scenes safe and keep us organized. Some ambulances have an external PA system, which is going to allow crews to speak to people outside of the vehicle. This may be used to give clear directions at scenes, during traffic incidents, or when coordinating with bystanders and responders. Many EMS systems today also use what's called a trunking system. Instead of everyone being locked into a single frequency, trunking systems automatically assign multiple frequencies as needed. This helps reduce radio congestion and keeps communications moving smoothly, especially during busy periods and large incidences. When it comes to radio communication and EMS, everything we do is regulated by the FCC, the Federal Communications Commission. This agency oversees all radio operations in the U.S., and their role is to make sure radio systems work safely, efficiently, and without interference between agencies or regions. The FCC controls which radio frequencies are assigned to EMS, fire, law enforcement, and other users. They also issue call signs, set licensing and operating standards, and place limits on transmitter power so signals don't interfere with other systems. In simple terms, the FCC makes sure everyone stays in their lane on the radio. This helps ensure clear communication, protects critical emergency traffic, and keeps EMS systems functioning reliably day to day. When the 911 call comes in, the very first person involved in our response isn't us, it's the dispatcher. Our dispatchers are trained to gather information quickly and determine how serious the call is based on what the caller reports. They're listening for key details like the patient's symptoms, level of consciousness, and breathing status, and any immediate dangers at the scene. Based on that information, the dispatcher decides what type of EMS response is needed and assigns the appropriate units. That might be a BLS unit, an ALS unit, fire, law enforcement, or some combination of all resources. As EMS providers, it's important to remember that the dispatch information is based on what the caller knows and communicates. It gives us a starting point, not the full picture. Once we are on the scene, we're responsible for reassessing the situation and adjusting care as needed. Beyond just assigning the call, the dispatcher continues to play a critical role throughout the response. They're responsible for selecting the appropriate EMS units, directing those resources where they're needed. At the same time, the dispatcher is coordinating with other public safety agencies like fire and law enforcement to make sure that everyone is responding together and safely. Another key responsibility of the dispatcher is providing emergency medical instructions to the caller by phone. This could include CPR instructions, bleeding control, or guidance on how to keep the patient safe until help arrives. Those instructions can be life-saving, especially in critical situations where minutes matter. As EMS providers, we rely on dispatch not only for information, but as an extension of patient care before we ever reach the scene. Communication with dispatch doesn't stop once we're en route. As EMS providers, it's our responsibility to report any problems that occur while responding. This could be delays due to traffic, difficulty locating the address, or any equipment issues. Keeping dispatch informed allows them to adjust resources and provide additional support if needed. Once you arrive on scene, we'll notify dispatch that we're on scene. This confirms our arrival and lets them know that patient care is beginning. Throughout the call, and especially when giving patient updates, all radio communication should be clear, accurate, and professional. The information that we provide may be relayed to responding units, supervisors, or facilities, so accuracy matters. One of the main reasons EMS uses radio and phone communications is to connect us with medical control. Medical control provides medical direction, guidance, and oversight for patient care, especially when we're dealing with high acuity patients or situations that fall outside of our standing protocols. When you contact medical control, you're essentially bringing the physician into the ambulance virtually to help guide our care decisions. It's important that you understand that medical control may not be physically located at the hospital that we're transporting to. In some systems, medical control may be at a different facility or in a different city. This means clear, organized communication is critical. The provider on the other end is relying entirely on the information that we give them to make decisions, so accuracy, professionalism, and staying within our scope of practice are key. When we consult with medical control, we're doing a few important things at the same time. First, we're giving the hospital a heads up that the patient's on the way. This allows them to prepare the appropriate staff, equipment, and a room before we arrive, which can save valuable time for the patient. Consulting medical control also gives us the opportunity to ask for advice or receive orders if needed. This is especially important in situations that are complicated, unusual, or outside of our standard protocols. Finally, it allows us to notify the hospital of any circumstances, such as a trauma alert or a stroke alert, or maybe a violent or hazardous situation. Clear communication here helps ensure a smooth transition once we arrive. In our system, it's also important to understand the role of our EMS supervisor. While our supervisors are not medical direction, they are highly trained and experienced paramedics with extensive clinical and operational knowledge. They are also an excellent resource in the field and can often help answer questions related to patient care, scene logistics, transport decisions, or even just those unusual circumstances. Utilizing the supervisors appropriately can help support sound clinical judgment and smooth operations. Another major advantage of our system is that our medical director is readily accessible, which is a huge benefit for our providers in the field. When situations aren't black and white or fall outside of protocol or maybe just require higher level guidance, we have the ability to contact our medical director directly. In addition, we can also consult medical direction at the receiving facility that we're transporting to. This ensures that patients receive appropriate care decisions and that we are supported when our protocols don't fit the situation perfectly. When we talk about giving a patient report, whether that's an over-the-radio report or a face-to-face at the hospital, the goal is clear, organized communication. A good patient report gives the receiving facility the information they need to prepare for our patient before we arrive. Most patient reports follow a consistent structure and include several key elements. You'll start by identifying your unit and your level of service so the hospital knows who they're talking to and what capabilities you have. If there's any type of special alert for your patient's condition, such as a stroke alert, a STEMI, or a trauma alert, we need to state that early. We'll also identify the receiving hospital and provide an estimated time of arrival so they know when to expect us. We'll then move into basic patient information, including the patient's age and gender, followed by their chief complaint. The chief complaint should be stated in the patient's own words if possible, and clearly explain why we were called and what the main problem is. Keeping this portion focused and concise helps set the stage for the rest of our report and keeps everyone on the same page. After we've given the basic identifying information and the chief complaint, the rest of our report focuses on the story and what we did about it. This still needs to be brief and to the point. We'll include a short history and the patient's problem. This isn't a full sample history. It's the highlights, and it helps the receiving facility understand how this started and what's important. Next, we'll give a brief report of the physical findings, focusing on what's abnormal and concerning rather than listing every normal finding. We'll then summarize the care that was provided, and including any treatments, interventions, and medications given, along with when they were done. Just as important, we'll describe how the patient responded to those treatments. Did their pain improve? Did their breathing get better? Etc. This response tells the hospital a lot about how the patient is trending. Finally, remember that a patient report is a two-way conversation. Be prepared for questions or additional orders from the receiving facility. Always pause at the end of your report to allow medical control or the hospital staff the opportunity to clarify details or give further direction. Clear, organized communication helps ensure a smooth transition of care and better outcomes for our patients. When we talk about medical control, we're really talking about how physicians guide and support the care we provide in the field. Medical control can either be offline, which is indirect, or online. Offline medical control includes things like protocols, standing orders, and policies that are written and approved by our medical director. These allow us to provide care without having to call every single time. Online medical control is when we're speaking directly with the physician or medical control by phone or radio. This is most often needed when a situation falls outside the standard protocols or isn't completely clear-cut. We may need to contact medical control for permission to administer certain treatments, to help determine the most appropriate transport destination, or in a situation where we're considering stopping treatment or not transporting the patient. These are higher risk decisions, and having direct physician involvement helps ensure safety while also protecting us as providers. The key thing to remember is that medical control is not there to slow us down. It's there to support our decision making, especially when things don't necessarily fit into the box. In many EMS systems, medical control is provided by physicians working at the receiving facility. However, there are many variations of this across the country. Some systems use freestanding medical control centers, while others rely on individual physicians who serve as medical directors for the agency. In our system specifically, we're very fortunate to have multiple layers of support. While our EMS supervisors, as I mentioned before, are not medical direction, they are highly trained and experienced paramedics with extensive clinical and operational knowledge, and they can help answer questions related to patient care, scene logistics, destination decisions, or how to navigate complex or evolving situations in the field. They're an excellent resource when we just need a little bit of guidance or another set of experienced eyes on the problem. We also have the huge benefit of having our medical director who's readily accessible. When something falls outside the protocol, isn't black and white, or requires physician input, we can reach out and get real-time medical direction. The key takeaway here is you're never expected to manage complex situations alone. Between experienced supervisors, an accessible medical director, and hospital-based medical control, we have multiple layers of support to help and provide safe, effective, and appropriate patient care. There are several different ways in which we can access medical control using ambulance to hospital communication channels, and that exact process can depend on which system you're working in. Most commonly, this starts with the dispatcher. The dispatch is actually actively monitoring radio traffic and is responsible for assigning us a clear and appropriate medical control channel when we need to make contact with the hospital or physician. In our system, we're able to just switch to the med channel directly that we wish to use. If for some reason we would need to activate Med 9 to speak with a physician more promptly or something like that, then our dispatch would help ensure that that goes smoothly. When you contact medical control, it's really important to be clear, concise, and intentional with the information we're providing. This isn't the time for long stories and unnecessary details. Medical control needs the key facts so they can quickly understand the patient's condition and make informed decisions. Stick to important information: who we are, who the patient is, what's going on, what we found, and what we've done about it so far. Think about it like this. If you were on the other end of the radio, what would you need to know to guide patient care safely? It's also important to avoid using codes unless our local protocols specifically allow or require them. Codes can be misunderstood, especially when communicating across agencies or facilities. We should use plain language. This keeps communication clear, professional, and safe for everyone involved. In our system, we do not use codes or 10 codes. When medical control gives you an order, it's critical that you repeat the order back word for word and receive confirmation before carrying it out. This is a safety step for both you and your patient. This ensures everyone is on the same page and reduces the risk of miscommunication. For example, if medical control says, administer 324 milligrams of aspirin by mouth, your response should be, copy, 324 milligrams of aspirin by mouth. You then wait for confirmation before administering the medication. This process protects the patient and it protects you. It also creates clear documentation that the order was clearly understood. It is also critical that you remember you must never act outside of your scope of practice, even if an order is given by medical control. As an EMT, you are only allowed to perform the skills and administer the medications that are allowed within your agency and state protocols. If medical control gives you an order that falls outside of your scope, such as an advanced airway procedure or IV medication administration, you must clearly state that you're an EMT and request an alternative order that falls within your scope of practice. In addition, you should never blindly follow an order that does not make sense or seems unsafe based on the patient's condition. Medical control relies on the information that you provide, and sometimes clarification is necessary. Good communication with medical control is a two-way process. Clear readbacks, confirmation, scope awareness, and professional clarification are all part of delivering safe and effective EMT care. In our EMS system, we communicate early with the receiving hospital anytime a call involves special circumstances that may impact patient care, staff safety, or hospital resources. For example, if we're transporting a patient from a hazmat incident, we would notify the hospital so they can prepare appropriate isolation, decontamination procedures, and PPE before we arrive. During a rescue in progress, such as a prolonged extrication from an MVC, early hospital notification allows them to anticipate trauma activations and a delay in our transport. In an MCI situation, early communication helps the hospitals manage surge capacity, staffing, and reallocation of resources. The early notifications ensure the hospital is not surprised by the patient's condition or circumstances and that they can deliver timely and safe care upon our arrival. In special situations, early communication is critical. Even if all the details are not yet known, providing early estimates allow hospitals and EMS systems to begin preparing their resources. EMTs should clearly communicate appropriate patient counts, potential hazards, and any other special decontamination, pediatric care, bariatric equipment, or law enforcement involvement that may be necessary. As more information becomes available, updates can be provided. Always follow your agency's established plans, policies, and incident command structure when managing these special situations. In addition to routine checks, EMTs should ensure radios are powered on, set to the correct channel, and able to both transmit and receive clearly at the start of each shift. Microphones, speaker volume, headset, and emergency buttons should be checked if equipped. If a radio fails during a call, the EMTs should immediately switch to the designated backup communication method, such as a secondary radio, a tough book or MDT, a cell phone, or so forth, and notify your dispatch as soon as possible. Communication failures should be documented and reported according to agency policy. If you can't communicate, you can't request help, medical direction, or resources. Radio checks are also a part of patient safety. In conclusion, effective communication and accurate documentation are foundational responsibilities in EMS and directly impact our patient care, provider safety, and the system performance. From the moment a call is received to the final transfer of care, EMTs must communicate clearly, professionally, and within their scope of practice. Whether speaking with dispatch, coordinating with other agencies, consulting with med control, or giving a patient report, the information you share guides decision-making and helps ensure continuity of care. Documentation is a permanent record of everything that occurred during a patient encounter. It should reflect clear, objective, and complete information that supports the care provided and the decision made. Good documentation protects the patient, the provider, and the EMS system, and it serves as a legal, medical, and quality assurance record. Together, strong communication through documentation demonstrates professionalism, accountability, and competence, all qualities expected of every EMT and essential to delivering safe and effective pre-hospital care.